Welcome, everyone. Please, as Catherine said, put your name and organization in the chat. We'll go ahead and go to the next slide and thank our partners. You're here at the Southwest meeting for the PATH Collaborative Planning and Implementation Initiative, which is sponsored by the Department of Healthcare Services and their third-party administrator public consulting group, or PCG. We'll go to the next slide and just cover a little bit of housekeeping as people are joining us still and coming into the meeting. As you put your name and your organization and share who you are in the chat with us, we also want to make sure people know what this place and space is for. This is for organizations who are interested in providing CalAIM services, particularly enhanced care management and community supports to people in the Southwest region and beyond. And it is a place for our contracted providers who are already providing those services, and for other providers in the ecosystem of care who are helping provide those CalAIM services to clients. It's not a place for vendors or salespeople to solicit or try to drum up business in the space. So if you are a vendor or salesperson, we'd ask you to recuse yourself for that purpose. And then we have a broader check-in question today. We wanted to just take a minute to take a deep breath as folks are joining us and sharing who they are, and wish you a happy spring, and wondering what you're looking forward to doing with your extra daylight hours. So you can come off mute and share verbally and give a shout out or put in the chat what you're looking forward to doing now that spring's here and you have some more daylight hours. Anybody want to share with the group? Longer walks after work. I love that, Tracy.
And longer walks with my dog.
Lots of walks with your dogs, Katie. Yes, that's great. Anybody else? More trips to the park. Love it. Sunsets. Wonderful. Well, we hope this is a time where you will speak up and share with us through the chat and verbally during this time. The Collaborative Planning and Implementation Initiative is here in the Southwest region across 5 counties. And we also at PHIL, the Population Health Innovation Lab, are the PATH CPI facilitators for the Northwest region, including Humboldt and Del Norte. And you're actually going to hear us talk a little bit more about all 7 counties today and some of the data presentations that you'll hear about later in the agenda. And we want to just talk a little bit about the agenda because last month, those of you who were with us, we know we have some new names to register this time, and we really want to welcome new folks to the table who are joining us for the first time. But last month, for the folks that were there, we actually had a poll around meeting times. And even though we had a lot of different responses, the winner of the meeting timing is 90 minutes. So today is our first 90-minute meeting, but we know there were 2 potential glitches. So we've organized the agenda for people to be able to leave after an hour. If for some reason your appointment didn't update with the 90 minutes, or like Nancy with Marin CIL informed us, there is another 2 p.m. Statewide provider network for ECM contracted providers that's that some of you may have on your calendar as well. So we've looked ahead to make sure we don't have that conflict with 90 minutes going forward. And we apologize today that you have to make a hard choice at 2 o'clock if you're going to jump over to the statewide meeting or not. But we do have some really great data analysis from our senior research scientists today around the data available through the Department of Healthcare Services data dashboard. We'll have our updates from both Kaiser and from Partnership Health Plan of California. Next month, our extended 90-minute time will have a deeper dive with Kaiser, and we're planning the second or the last 30 minutes to really be a really robust presentation and discussion with Kaiser. But today we'll have our regular updates. We'll have a great local organization spotlight from COTS, which will get us ready to talk about revenue and program enhancement strategies with a deeper dive into partnership health plans, ECM quality improvement program. So with that, we're going to shift over to our objectives for the day. As we dive into our agenda, we really want this to be a place where there's transparency to share with each other your challenges, your successes, your innovations as you look to implement CalAIM in our region. We hope that you'll be able to really glean some new information and share with us your insights around the utilization data that Sean will share and how we're using that to inform our current and future work with you. We really want to start to, have more discussions about revenue enhancing strategies with you. And of course, I encourage you to really use this time for shared learning and open dialogue with each other. And with that, I'm going to turn it over to Jessica to just further frame our time today. Thank you, Jessica.
The Phil team respectfully acknowledges that we live and operate on the unceded land of Indigenous peoples throughout the United States. And I've moved, so today I'm working on the ancestral and unceded homelands of the Gabrieleño Tongva and Gabrieleño Quiche peoples. I encourage you to click on the link that Catherine is putting into the chat today to learn more about the native lands that you are living and serving from today. Next slide, please. And as always, we like to start with a couple of different objectives from our commitments to community inclusivity that we can listen to and really embrace in our upcoming hour and a half. And today I highlighted in the second box in the create an inclusive space, the third point, which is to resist the temptation to only witness dialogue and instead take place. And I especially encourage this after we hear from COTS, as there's lots of opportunities to learn from one another. And lastly, to be accountable. And that last point is to practice patience and persistence. We cannot solve everything in a single conversation, and we will revisit topics that require additional discussion. So listen, embrace, and hopefully pursue. Next slide, please.
Thank you, Jessica. And with that, I'd like to introduce you, if you haven't met already, Sean Aluko. He is, as I said earlier, the Senior Research Scientist with Population Health Innovation Lab. And if you go to the next slide, I'm just going to set up a little bit for Sean, some of the terminology that you'll be hearing him reference using the state's new data dashboard. Sean's become a resident expert on both the public-facing dashboard as well as some of the behind-the-scenes data that he's able to analyze for us as a facilitator group. And so when he talks about populations, that's going to be everyone who's eligible for Medi-Cal and is a member of Partnership Health Plan of California, or now Kaiser Permanente, as the two Medi-Cal managed care plans in our region. Even though we have limited, data so far, of course, for Kaiser because they most recently joined. When he talks about enhanced care management penetration rates, that means the percentage of overall members who are receiving ECM services in the county. And there's been some talk about how many people, right? How many people are out there that would get each of these services under ECM and community supports? So right now, this is the official statement we have on the slide that the state is saying they're expecting 3 to 5%, but they're actually not making any explicit targets right now for penetration rates or goals. They're just providing baseline information and acknowledging a lot of variety across the state and across Medi-Cal managed care plans. And really, I think the biggest piece for us that we're acknowledging is that the importance of data and looking at the trends and collecting that. For us at Phil, we actually are having a goal of 5% as our goal based on what we know about research and data and the populations in need of ECM in our geographic area. And you'll see other terminology like capacity, but I know as Sean works through the next few slides, he'll further refine and explain these topics. So thank you, Sean.
Of course, next slide, please. Like Tammy said, every slide that I will go through here will cover data that includes Del Norte, Humboldt, Lake, Marin, Mendocino, Napa, and Sonoma. And so it'll include counties from both Northwest and Southwest regions. Again, it is only inclusive of partnerships data and does not yet include any data related to Kaiser. And for some of the screen grabs that I got from the dashboard, you might see in some subsections where your county might not be reflected. This is just due to the limitations of not being able to edit what is being shown to the extent in the dashboard, but rest assured that all counties numbers are reflected in the total numbers that are being shown on each slide. And so to jump right in, this first screen grab that I got is essentially on the network of enhanced care management. This dashboard again shows data across all 7 counties, and the time frame is up until the end of last year, Q4 of 2023. As you can see in the top middle of this dashboard, as of the end of the year last year, total ECM providers across all of our counties, these 7 counties reached 89 providers. This is a huge growth from 38 providers in Q1 of 2022. Steady growth across each quarter in this region, which is great. Out of those 89 ECM providers, it's important to also call out that 34 of them are also delivering community supports, pointing to kind of like a specialized subset among the ECM providers. Another thing that I really like to call out here is the capacity over time dashboard in the middle of the screen. As you can see, at the beginning of the year 2022, we had about 2,000 providers. We had a capacity for about 2,000 members to receive services. By the end of last year, capacity as estimated by DHCS based on provider reports had reached about 21,000 by the end of last year. Another important number to call out on the dashboard is in the very top right under total capacity filled. 6,874 units of capacity have been filled within this network. That's about 34%, and so showing that a significant portion of available capacity is being utilized. However, also showing that we still have a lot of capacity to use as well. And then to draw your attention to the bottom left of the screen, you'll see this population of focus served dashboard. These bars essentially show different population groups served by ECM. And as you can see by the top 2 bars, adult families experiencing homelessness, adult individuals experiencing homelessness are at the top 2 with 73 providers serving those population of focus. Not too far behind are adults experiencing severe mental illness and substance use disorders. And essentially a lot of data on this side, but overall, I think something that's just overall really important to call out is that this dashboard shows an expanding and diversifying ECM network in the past year and a half, with not just an increase in the number of providers, but also an increase in the capacity that the providers are offering. Next slide, please. And similar to that, in the internal dashboard, there is also another fun community supports network dashboard. In the top middle of this screen, you will see that there are now 96 providers in total, a growth from 20 at the beginning of 2022 that are providing community support services. 80% of these providers, and I think this is a great fact, which is 76 of them, provide more than two or more types of community support services. Again, kind of highlighting the breadth of services being offered by providers in our regions. Total provider capacity is standing as of the end of last year at 85,000, indicating the potential to reach lots of members. This 85,000 is an increase from about 4,100 at the beginning of 2022, which is a huge difference in a short period of time. Community supports, again, the top support types as shown on this dashboard are support services related to housing transition, as can be seen in the bottom, second from the bottom right. Housing transition services, 67 providers provide this service. 64 providers are providing housing tenancy and sustaining services, and then housing deposits, indicating a specializing, for lack of better words, in this Northwest Southwest region of community supports focused on housing. And again, similar to the ECM dashboard, this dashboard shows an increasing network of community support providers that has been increasing in both number of providers and also been increasing capacity. Next slide, please. And so provider increase in contracts, number of providers going up is one thing. I think it's also important to talk about the members that are being served and what the trends look like there. And so this ECM enrollment dashboard is focused on the member side of things. And so as can have been seeing in the top right of this dashboard, the total numbers of individuals enrolled in ECM program has grown year to year. By the end of last year, it reached 2,457 members. Some topics on enrollment dynamics. Last quarter alone, Q4 saw 2,186 individuals receiving ECM services across the 7 counties, with a cumulative of 3,688 by the end of last year. And again, similar to the previous dashboard, the primary ECM population of focus is predominantly adults experiencing homelessness and adults with severe mental illness or substance use disorders, with about 1,000 members enrolled. Next slide, please. And then last screen grab from the internal DHCS dashboard is focused on the community supports. And so again, there's been a steady number of individuals receiving community supports in our 7 counties. This number went up to 985 individuals by the end of the year last year, up significantly from the 1 or 5 in Q1 of 2022. Again, similar to the previous slide, community support types, housing transition and navigation services is the most provided type, with 439 individuals served. Again, showing a focus on housing services and housing stability across the Northwest and Southwest region of Northern California. Largest population being served again is adults and individuals experiencing homelessness, as shown in the bottom right dashboard, followed by adults with severe mental illness or substance use disorders. I think something that's also super cool to call out on this dashboard in the bottom right again is since children became a population of focus about 9 or 10 months ago, I don't remember the exact number of months, you're starting to see them creep up into these dashboards. These numbers were 0 in the past, but we're now starting to see that eligible children in the population focus are now receiving community support services as well. Next slide, please. And I see that there's some chat numbers popping up on my end, but I can't quite see the chat yet, but I promise I will circle to your questions right after these slides. And so we decided to put, this graph essentially represents ECM penetration rates as reported on DHCS's publicly available dashboard. It was depicted on that dashboard in a table quarter to quarter, and we decided to just put it on a graph just because sometimes it's nice to see trends as over time. And I think it's really cool to kind of call out, starting in 2022 to the end of last year as what is available on the dashboard, there's been clear uptick in trends of ECM penetration rate in every county in our Northwest Southwest collaborative, all starting at essentially 0, as they are all inching towards a 1% penetration rate. I know this data has a quarter lag from what is available on the HCS publicly available website, but as of what they've posted, Marin has a 0.91 penetration rate, Mendocino at a 0.82% penetration rate, Sonoma at a 0.71% penetration rate, Del Norte 0.62%, Lake at 0.37%, and Humboldt at 0.34%. I think overall the biggest takeaway home point from this graph is it really indicates a general positive trend towards ECM penetration in all counties. And I know a lot of people have been talking about, oh, we're going to start seeing a plateau sometime soon. But as you can see on these graphs, it does not look like it anytime soon. And I really look forward to what this graph will look like in the next quarter. Next slide, please. And so I've been throwing out a lot of numbers at you, and I will continue to throw out some more numbers at you, so bear with me. Penetration rate, for some reason I saw that question, is the number of eligible ECM members in the last 12 months. Well, the number of eligible ECM members who received services in the last 12 months divided by the number of eligible ECM members in the last 12 months times 100. And so the DHCS essentially gets a penetration rate for what percentage of those who are eligible to receive ECM services in the last 12 months actually receive services. Hopefully that answers the
Yeah,
question.
not eligible for Medi-Cal, not for ECM services. Thanks, Sean. Yeah, I'm sorry, because I know I was bumbling at the beginning for the definitions, but it's the percentage of everyone who, people on Medi-Cal, which is on Sean's chart he's about to walk you through. It's the column,
Second from the left.
yeah. And the math is the number of people receiving ECM services divided into that total.
And once again, this does not yet include Kaiser's data, and we will not have that till the next quarters.
John, sorry, I apologize, but on the right, I think that there shouldn't be percentages in all of those columns. I think what you were trying to show there was if we got to a 5% penetration rate, what would that number be?
Yes, so this table
that percentages there, those aren't percentages, those should all just be numbers, correct?
No. Okay, so essentially, you're jumping way ahead of me, but glad you're really interacting with this data table with a ton of percentages in there. Essentially, what the right side of this table is doing is what we did was after graphing the trends for last year and seeing where we are by what was publicly posted, and trying to work towards that 3 to 5% penetration rate across our regions. We were curious of, okay, 3 to 5%, great numbers. What percent change or what percent increase of members in each county is needed to even get to 1% penetration rate, let alone 2, 3, 4, and 5. And so in the rightmost column of this table, that 61% that you're seeing there is saying that in Del Norte, we need a 61% increase in the numerator of, which is essentially the number of unique members receiving ECM services in the last 12 months. We need a 61% increase in that number to get to a 1% penetration rate. And then for Humboldt, we need a 197% increase, Lake 173, Marin 9, 22, Mendocino 22%, Napa 41%, and Sonoma 41%. If you go to the 5% penetration rate column, we need a 704% increase in the number of unique members who are receiving ECM services to get to a 5% penetration rate in Del Norte, 1,387% for those in Humboldt, and all the way down. And so these percentages are essentially representing what magnitude of change we need in the number of eligible MCP members who are receiving ECM services in each county. And I put it this way so that we can this goes into my next point for how we updated our aim statement, essentially, so that we can set some targets that are ambitious and also realistic and reasonable across our CPI counties. Next slide, please. And so, like I said, the percentages increase needed help set benchmarks for our ECM enrollments and what our new aim statement is. And so here's what our new Southwest aim statement is. The Southwest Path Collaborative Planning and Implementation Initiative aims to help improve the quality of services for members who are eligible for enhanced care management and community supports, as well as increase the number of local providers by 29% and expand the number of Medi-Cal members receiving CalAIM services by 100% by the end of this year. The CPI will facilitate this by supporting the progression of CPI participants along the readiness roadmap, which some of you are familiar with, to effectively integrate ECM and community support services within the Medi-Cal system. And so essentially that table that we showed on the previous slides, we were taking weighted averages of the population in each county, the percent change needed in each county, and what that would look like to get the entire region to get to a 1% penetration rate. That exact number was around 95 point something percent. We rounded up to 100% to just give us some wiggle room to be able to hit that 1% penetration target by the end of the year. From what I'm seeing, I really suspect that we will likely hit that target before the end of the year, but a win is a win. And then the 29% increase in local providers, this was calculated from the total number of providers that we know are not yet contracted in the Southwest region, and also looking at the quarter-to-quarter growth in provider contracts with partnership health plan to help determine what was a feasible target for increasing the provider network by the end of the year. So that is essentially how we got to this aim statements. And again, kind of addressing that, access to data is one thing, aggregated numbers that we use to, come to all these conclusions is one thing. Those things never really tell the full story on the ground. And we're recognizing as we move forward in this CPI, collaboration still remains the biggest thing for us, and we always lean on the ground partners to provide us the contextual information for challenges being faced. Maybe thresholds might need to get changed, but recognizing all the providers here play a vital role in helping our CPI collaborative reach these targets. And as shown on that graph, lots of momentum in the past year and a half, and we really hope to carry this momentum forward into the next year as we, reach that 1% penetration rate across the Southwest region. Okay, I will open the chat now and try to find.
Yeah, so that we have chat questions, we have hands raised. So we know this is going to be a robust dialogue, and really appreciate this time with Sean to kind of delve into your reflections, how else we can utilize the data. I think just framing that we have these the piece of question I just saw here. The 100% for us is across community supports and ECM, and I know as Sean answers some of the questions, you'll know some of the challenges we have with community supports. Certainly, this is a very dynamic and disparate, if you will, region of 5 different counties. So one thing we will be doing is some county level work groups with this region to really delve into the data and the ecosystem of care and the assets and the provider networks at a more localized level with you over the next several months. But this is a roll up of our target across the region, as Sean had said, and certainly is different in the Northwest versus the Southwest region as well. So with that, Sean, I don't know if you want to start with the questions in the chat, or if you want me to take the hands in the room for you.
Let's go with the hands being raised. I think you just covered all the questions in the chat.
There's probably more detail for community supports one in the chat, but that asked about the number of people versus services. So there was an 85,000 number, I think, on your community supports screenshot that Catherine Couch had saw, and I know that is not people, it's services, but anything else you can elaborate about that?
That 85,000, that was on the network of community supports. And again, remember, capacity, that number as DHCS defined it, is number of members that could potentially be giving services based on providers estimate. And so DHCS was estimating that at the end of Q4 for last year for community supports, that the provider, at least the providers contracted with partnership across these 7 counties, could provide up to around 85,000 different community support services.
And that there's some flaws in that. That's provider reported capacity, and again, how community supports are being filled in on a per service basis. I think there's going to be a lot of improvements with the state dashboard over the next year to help refine that. So I'm going to take the hands in the room in the order I see them. Amy Anderson.
Hello. I just really quickly, and this may not be helpful, but I wanted to reframe the penetration rate information that was being shared, because I've gotten a little side questions on it. So could you go back to the slide that showed all of the members in the county, like maybe one right there? No, go one more.
Yeah. There.
So when we're talking about penetration rate, it implies a lot of stuff. It implies that members want to be enrolled in the program in like perfect world kind of scenario. But just for example, in Marin County, is this partnership?
Yes.
Okay. So if partnership has 51,000 members, and we get the full 5%, which is the ECM base of 3 to 5% of those members, that means of all of the partnership 51,000 members in Marin County, approximately 268 of them should qualify for ECM services. Like that would be our target 100% penetration rate in Marin County. So from a number standpoint, that's what's being discussed is not everybody, not all 51,000 would qualify for ECM.
Right.
The example is 5% of those 51,000, and then also 5% of Kaiser's numbers, whatever Kaiser has. So that's what they're looking at. The whole point of all of this information is that even though there are 500 million of us providing this service, we have not even like gotten to the lower threshold of what DHCS thinks members can get. And so that's really
right.
the take-home message in this scenario is that there are people out there we're not getting. There are people out there that are either saying no, or that we're not finding, or that are falling somehow through the cracks. So there are lots of friends for us to go and support and serve. So I just wanted to reframe that.
Thank you for reframing that and for saying that again, that this is the whole purpose of making this a focus is that last year, only 470 people received ECM services in Marin, and we would expect that over 2,000, so 2,500 plus could be benefiting from ECM in Marin County. So thank you. That this is actually our call to action and why we're having this conversation. So thank you for that. And Catherine Couch, go ahead.
So I also want to kind of dig in a little bit. I love that you guys are setting a goal around this. But I want to just think aloud a little bit around where the leverage points are. Because, for example, I mean, we have counties with very much smaller provider networks in place than other counties.
Yes.
And so there's, we need to enroll providers, we need to get providers up to speed and scaling, and then existing providers need to scale over time.
Right.
So just thinking about where are we most kind of not making the mark right now, and how do we invest, I think is really important. I mean, we have a scaling plan in place for this year that's pretty significant. We're stuck right now, right, because we're waiting to move into a new facility, so we have limited capacity in the short term, but we are we're shifting our client base to take on more Medi-Cal members within our existing kind of client capacity. But there's counties where there aren't existing providers, or they're very, very small, or so I'd love to hear you guys talk a little bit about, we're in Sonoma County. We probably have the most service providers, or Sonoma and Marin do. What's the work in Lake? What's the work in Napa? What's the work? Because that's where, and then how, I think the other just big thing. So we're going to be piloting in Napa, Lake, and Solano over the next couple of months. So I think there's also some really big challenges with the way that community supports and ECM, community supports in particular, is set up, that the rates right now don't really allow us to scale to other communities, even when there aren't providers in those other communities. So there's a lot of, I guess what I'm trying to point to here is there's a lot of different potential solutions to get to your goal. And I think it's really important to break them down and think about what are the strategies for where there are different kinds of gaps, and what are the possible solutions to reaching those. So that was very rambling. I apologize for not being clear in my communication, but
no, we said we could spend the whole 90 minutes just talking with you all about on this topic alone, on the data, because really building on those county work groups, we have some ideas, but it's going to take all of you kind of helping us fill in those gaps to do some build on the county level asset mapping that many of you participated in last spring, and then really looking at the ecosystem of care, but then also looking at these subgroups of community supports and ECM populations of focus, right? And knowing the provider networks are really different, but to your point, also really different from Lake County to Sonoma County, right? So, so we really want to help support that work and to work alongside and with you all to really build out those nuances, and that a year from now we'd have much more granular information that really helps us all provide those localized services to local people living in our communities. So Erin Hawkins, next question.
Thank you. Can we go back to the very first slide, the enhanced care management slide? Okay, so the by population of focus served, could you say again, just talk us through what those numbers represent?
So there are two enhanced care management slides. This one is focused on the network. So the numbers here reflect providers. The second one, all the numbers on that slide reflects members. And so here in the population of focus served across the counties that we're filtering by, which is Del Norte, Humboldt Lake, Marin, Mendocino, Napa, and Sonoma, as of the end of last year, DHCS dashboard is showing that we have 73 providers who serve, adults, families experiencing homelessness, adult population individuals experiencing homelessness. 72 is serving adults, avoidable hospital.
Got it. So it's the number of individual agencies providing services
Yes.
to that target population. So then if you go to the other ECM slide focused on clients and look at the population of focus and on the right-hand side, those percentages. And for example, if we took child welfare, which says, was that 0K?
Yes, and so this is one bad thing by this dashboard. It rounds to the nearest thousand, and so that it's definitely not zero, but it is a number less than 500, and it's depicting it as zero. But if I were,
sorry, go ahead. First of all.
And so if I were to if this were the live dashboard and I were to hover my mouse over this, you would be able to see the actual numbers there. But it's reflected as 0K right now just because of how much larger the population of focus is in the individuals experiencing homelessness, adults experiencing severe mental illness and substance use disorders. Is just kind of washing out those small numbers.
So what we can tell from this, like looking at those two slides, is there's very few children, like you said, getting not only into community supports, but ECM. And we also see there's also a corresponding connection of nearly as many agencies that are targeting children. So is there any way, and I ask this because I work at a community action agency that hosts Head Start and state-funded preschool programs for infants and toddlers and expectant moms. And so I'm making the case to our agency to move in not just to the community supports work, but into the ECM work. And I'm wondering, is there any way, any data that would give an indication of how many children we think there are, or any of these populations, who would be, or are we simply working with a penetration rate around how many children we think would qualify, for example, in child welfare for ECM compared to the number who are actually getting them? Are we able to, is there
I think, yeah, we what we've done, even the 5% goal is based on some deductive, reasoning. So I see Amy's writing something in the chat, but I'd love to talk with you more, Erin, because also some follow up on some work groups really wanting to dive into how to share knowledge across agencies and really get at some numbers. So yeah, we don't have an answer for you today, but would love to look at some proxy numbers for that. We have data on number of child welfare cases in each county and those things that we could kind of build out approximate numbers with you.
But the big takeaway is very few kiddos are getting served and very few agencies.
That's right.
Are serving them.
Yes. Lots of need, lots of space for services to be provided. Tracy.
I think actually I'm asking a question that a few people have asked. And first I want to say thanks, Cian, for a super informative presentation. Really appreciate this. My question was, should the penetration rates be linked to the prevalence of ECM eligibles? I mean, I think that's one of the questions that several people have brought up. Otherwise, they seem arbitrary.
I know they
As-
do, and it's partly why we did that terminology definition, and it's probably a bigger, but that is the definition of penetration rate, you know, across for this, but I think that is the big question. Everybody wants to know what's the estimated number in each of these populations, and even the state has said we don't officially have a number. You can it's a much further discussion, and we actually only have 60 seconds left for this section in the
Okay,
agenda. So I'm gonna let Nancy and then Lynn Scurry wrap it up. So Nancy.
Great, thanks. I wanted a quick question on, do you see members as going on, you know, for a year and then going off and then coming back on? Because if I'm looking at those numbers, the numbers that Amy went through, right? 50,000 in Marin, 5% gives you 2,500, and say 20 ECM providers, then we're only talking, you know, about, well, there's 470 already received, right? So that leaves about 2,000, 2,100. So, and 20 providers, that leaves 100 members per provider over the years of CalAIM. So unless you expect members to keep coming back onto CalAIM after they've been served, it doesn't make economical sense for us CBOs to build these platforms. So I'm trying to figure out,
Yeah.
once we hit 5%, what happens?
Yeah, no, I think it's a great discussion, and I don't know if Lynn has any final reflections for that, but to say this is if this is a once in a lifetime benefit, if you will, and then folks are served, you know, kind of what's the churn through both Medi-Cal itself and CalAIM. It's a bigger discussion, but I think Nancy, we will be working on some responses for that. And Lynn, any final thoughts or questions for Sean?
Well, a couple things, just an answer to Nancy's observation. You know, some of the benefits are once in a lifetime, and those of us who work in this area know that that's somewhat unrealistic. But the state, you know, I think was hesitant to open the floodgates. So, you know, I think we're all hoping that there'll be some flexibility there. And with enhanced care management, the same member can be enrolled for 24 months or can re-enroll. So it's really only the community supports that have those really hard restrictions right now. So I think we all just need to be a little bit flexible and patient as we see how things roll out. And, you know, the 3%, 5% are based on kind of industry data that shows that's, you know, of any managed care population, about 5% of the individuals will have the types of conditions that could benefit from case management. But again, you know, we're a different population, and so those numbers may change a little. And lastly, I know time is short. I wanted to introduce Carolyn Moulton. I think I put a little bit in the chat, but Carolyn's working out of the Santa Rosa Partnership Office, and she's new, but one of her specific areas of focus will be helping develop the network of ECM providers for youth. So really, we're not the CalAIM experts, but we're hoping to help facilitate and do outreach to members to get, to answer some of those questions about who's contracted in the network and who else maybe should we be reaching out to expand, because we do think there's great need for more ECM providers in youth. But it, again, as Amy pointed out, it's a relatively new population of focus, so we're just kind of getting some traction there. So I definitely expect to see those numbers grow, and I think Carolyn will be helpful working with you all to help us develop that network.
Thank you. Thanks, Lynn. It's great to have you and Carolyn here. And we actually are going to transition to an update from Partnership Health Plan with Ashley Peel and Paula De La Cruz with the ECM and community supports respectively. And I know there were a couple of other questions in the chat. All the slides will be shared in a post-convening email that Jessica will send out next week. And we'll have links to the slides here and other timely resource available information. So with that, Ashley, are you with us?
I am. Hi, Tammy. Thank you. Hello, everybody. Good afternoon. Happy April. I can't believe we're already middle of the month. I'm not going to take too much time today. I don't have any updates, just a few friendly reminders. So again, keep coming to those provider roundtables. Our ECM provider roundtable is happening tomorrow at 12 o'clock, and then community support's next roundtable is next month. And then our ITP funding opportunity is still live. You have until the 26th to submit applications for those, so definitely take advantage of that opportunity. And I will put the grants email inbox in the chat so that you can reach out with any questions related to our ITP funding.
Thank you so much, Ashley. I'm sure people are busy trying to finish their applications for next week. Thank you for making that a streamlined process. And if there aren't any other updates from Paula or Janine with community supports, thank you, Ashley, for joining us today. And thank you all for engaging in conversations with Sean and Luco. And as we transition to Kaiser, I believe we have Vanessa and Andrew with us with Kaiser today. That's correct.
Oh there. This is
Oh,
Andrew.
hi.
Yeah,
Hi,
nice to see some
Andrew.
familiar faces. Jessica, Tammy, Catherine, our folks from Phil. Glad to see you again. But yeah, quick announcements. I know we're running up on our agenda here, but first, I want to thank our path facilitators for helping us distribute our Kaiser survey. We had distributed out to the community to capture some ECM and community supports gaps. So we're planning to share that input that we've received more formally in the upcoming meeting. So I think it's a great way to, one, get the voice and hear what's going on from the community, and share what we've observed as well. So want to get an opportunity to share that back at a future meeting. Couple quick updates on ECM. We've launched we entered into Marin, Napa, Sonoma counties. We've launched the birth equity population of focus and the justice involved population of focuses for enhanced care management. So just wanted to make sure that people are aware that we're accepting and welcome referrals in that space. So we're continuing to work with other MCP partners to make sure that there's a 100% justice involved overlap across all of Kaiser's footprint, not just the ones in the Southwest Collaborative, but I wanted to share that. And I know that for community supports, I know that Kaiser is planning on launching new community supports services in a few select counties as well. So wanted to call out that day habilitation and asthma remediation services will be launched soon. I think the target aiming for the elections is July 1st. So that'll be available in where Kaiser members are seen in Marin, Sonoma, Napa. Just wanted to kind of call that out.
Great, thank you, Andrew. So as Andrew mentioned that he and Vanessa are working on a much longer presentation for next month. We're hoping for the May convening that the last half hour of our meeting will be dedicated to those three Sonoma County, Marin County, and Napa County Kaiser counties. And so we'll bifurcate the agenda and make the first hour really robust for everyone, and then the last half hour for those who want to stay and have that deeper dive into questions and answers and discussion with Kaiser. So really appreciate you being here today, Andrew, and preparing for next month to just do that deeper dive into the provider network, the IPP process and responses, and your referral processes within the network that's developing. So any immediate questions for Ashley or Andrew before we transition to our big topic of the day? Thanks, Vanessa. Great. Good. All right. Well, I'm really happy to go to this next slide just to give you a little framework. We don't have a lot of time today to talk about revenue enhancement strategies, although we want to develop more space for more peer learning around what folks are doing. The first green box up in the upper left-hand corner is just your contract, if you're contracted already, to bill for enhanced care management and or community supports. And then, of course, the PATH funding for PATH-sided grants and special grants that are coming out for the justice involved population, for the TA marketplace in-kind funding that you can get. So services free to you. And we want to keep trying to help you apply and get those resources in kind. And then what Ashley mentioned, of course, right now, this really unique opportunity that Partnership Health Plan has IPP funding available if you apply by next week right now. And then Kaiser is getting ready to release some funds later this year in IPP funding. And we want to dedicate more time in future meetings to talk about what you're doing to braid other states and federal funding and other nonprofit funding into your organization. But today we have a great opportunity to focus on quality incentive program funding, which is unique to Partnership Health Plans, ECM services. And I'm really happy to first introduce you to Shannon Gary, who is going to share a little bit about how the Committee on Homelessness, I hope I'm getting COTS right, Shannon, Committee on the Shelterless, COTS in Petaluma has been integrating the ECMQIP into their programming. So thank you, Shannon, for being with us. I'm going to turn the mic over to you. And I know Jessica's going to help you transition to your slides and give us a little insight into your experiences.
Hi, I am Shannon Garai, and I am the Senior Programs Administrator at COTS. And let me just go ahead and start sharing my screen. And I'll share a little bit about what's been going on in our program with our process towards the ECMQIP funding. So just a little bit of information about COTS. We're located at the south end of the county. As you're driving down 101 headed towards San Francisco, you can actually see our headquarters at the Mary Isaac Center from the freeway. And our mission is to assist those experiencing homelessness to find and keep housing, increase self-sufficiency, and improve well-being. And as you can imagine, CalAIM really fits well to support this mission. We're excited to be able to implement those services at COTS. The ECM populations focus that we serve are actually the ones that I was seeing as the most popular on the data we were just looking at. So adults and children experiencing homelessness, adults at risk for avoidable hospital or emergency stays, adults with substance use disorder or serious mental illness are the top 3 populations that we're serving. Here are some of the programs that we offer at COTS. We have on-site meals for clients and the community. Anybody who's hungry can come for lunch or dinner and grab a meal. We have recuperative care services, emergency shelter for individuals, non-congregate shelter for individuals, a family shelter, permanent supportive housing, community housing, and rapid rehousing. So we're offering ECM services in these programs currently. In 2023, COTS was able to serve 156 individuals with ECM services. We averaged 112 members per quarter. We had, on average, we started out with 6 care managers and we grew to 8 care managers. And for every quarter of 2023, we earned 100% of the ECM funding that was available to us. Another thing I just want to mention is 2023 was the year that we officially went live. January 1st, we had all of our folks were already trained and we were starting to generate TARs and implement our services. So this is really our first year of ECM. Here's some key things that we learned about the ECM QIP and processes that we found helpful. So the first thing is having a reliable tool for keeping track of data has been essential to us. And I'm going to talk about the tool that we use in just a little bit. It's pretty simple, and I think everybody can have access to it. We also monitor the QIP measures throughout the quarter rather than waiting as you come close to the end of that. It makes a huge difference in terms of being able to correct our course if we're a little bit off in some areas, and to just make sure that we're providing the services that our clients need, and at the same time meeting the measures for the QIP. Also, communication has been so important to us. We communicate early and often. The communication between the CalAIM administrator and care managers really is the key to success to keep things running smoothly. Here's just a description of some of the tools and things like that that we use. We have updated our electronic case management system to capture blood pressure and PHQ-9 data. And we added an Excel export so that we could very quickly have our hands on current data, manipulate it, highlight what it was that needs to be done or changed. We also monitor point-click care, or actually when I'm with my team, I tell them I'm stalking point-click care. Because we want to ensure that all of the client records are available. Sometimes it takes a little while for things to show up. And we also want to make sure that the care plans have been uploaded and that they've been named appropriately and all that stuff. And then finally, the last tool that we use is we actually took the ECM QIP template, submission template that Partnership provides, and we modified that to create a process for some internal analysis. I'm going to just put my phone on silent. I thought that it was. Okay. So those are the three things that we're doing just to keep things going. And I'm just going to show you. Oh, I forgot to tell you, the biggest thing that we really like to do is keep everything in one place so that it's easy to keep track of and pay attention to. So this is the template. As you know, this is the new template that came out at the end of March. And all of this information is pretty much the same. So we really use this section of the template over here, starting with patient name all the way to the end, to kind of create our own little running list of who we're serving. And we also added some extra columns to create that one tool, that one resource to be able to keep track of everything in one place. So those extra columns are the TAR submission date, the date things were, the individual care plan was uploaded into point-click care, and the date the ROI was uploaded into point-click care. So in this way, we're able to pay attention to the point-click care information, as well as making sure that our depression screenings are up to date and meet the requirements, as well as the requirements for blood pressure. The other key to this is really has been managing our teams. We have some established workflows and processes for our care managers. I'm going to talk a little bit more about how we closely monitor point-click care. And then the other thing is we're always talking about ECM and CalAIM and community supports. It's always an agenda item at our team meetings. So here's an example of one of our workflows for our care managers. So we would they start by submitting that TAR, and then at the same time, they're notifying their manager and also the CalAIM admin person that it's been submitted. And then in point-click care, they're uploading the individual care plan and the ROI right away if they can, if the option's available. If it's not available, then they're just emailing the CalAIM admin just to make sure that everybody's got the radar on about that there may be some need for some support with that later. And then the care manager also keeps a running list of clients who aren't in point-click care, and then they follow up and look again at the end of the month. And if they don't show up at the end of the month, then another notification is going to the admin just to make sure that, you know, if there's some need for some troubleshooting or something like that, that it can be done in a timely fashion. And then the second workflow we have is around blood pressure readings and PHQ-9 scores. So we're administering the blood pressure and PHQ-9 at our initial care management meeting. We're documenting it right afterwards in our electronic case management system. And then any scores that are outside the recommended parameters for Partnership, we're repeating on a monthly basis. So then the second kind of area that we look at is we've got one central point person who is monitoring ECM data and communicating about that. So that person is monitoring point click care, making sure everybody's got access to their clients in the system and that all the documents have been uploaded. They're also taking a look to make sure those documents have been properly labeled, that the right individual care plan has the right client's name and information on it. And they also act as a point of contact with partnership and point click care if there's a technical issue that arises in the portal. Emails go out to both at the same time so that everybody is in the loop that this organization is really working on trying to meet their measures and that the communication is just open and honest about where we're at and what we need. And then we also track updates and changes as new information comes in, and we're communicating with care managers if there's a new client that was added or we were able to make some progress there with point click care. If we're noticing that their blood pressure scores or PHQ-9 scores are missing or out of date or outside of the parameters of what partnership is looking for on the QIP. And then we're also letting them know if there's documents that are missing or incorrectly labeled. And then the last area is around communication. I got some more things to say about that. So I'm not sure what I did with my, oh, it looks like I put the checkpoints in before the boxes. Okay. All right, I see. So we're making the ECM-QIP measures a team agenda item, a team meeting agenda item. We're sending email reminders ahead of deadlines. We're making time to discuss strategies for clients who are resistant to getting their blood pressure taken. And we're expressing appreciation for efforts. So just a little bit about discussing strategies. One of the things we really like to do in our team meetings is do a little bit of storytelling about what's working or what troubles we're having. And recently, one of our care managers was telling a story about a gentleman who literally runs away from her anytime the mention of getting their blood pressure taken comes up. He literally takes off and runs the opposite direction. So her strategy has been that she doesn't mention it, but when it's time to take him somewhere and she's giving him a ride, he hops in the car or in the truck with her and they'll be talking on the way and he will say things like, I'm not getting my blood drawn today. Nobody is taking my blood pressure. I'm not doing these things. I don't even know why I'm going to this appointment. And then she'll just reassure him and remind him. And eventually, often when it's time, the way that she gets the blood pressure score is right there in that truck. Somehow the conversation is safer in the truck than in the care manager's office or any of the other places that they meet. He's more willing to participate and engage there. So she's literally meeting him where he's at in those moments just to make progress. So these are the kind of stories and strategies that we share with one another just to offer some encouragement, keep our strategies for serving folks creative and innovative and you know, it gives us a little bit of an opportunity to laugh at like some of the crazy things we're willing to do just to make sure our folks are served. So getting back, so that leads to we're appreciating all of those efforts of those crazy things that we're willing to do and those great efforts that we make. And then to that point, we celebrate all successes, big and small. So if you are an organization that is nervous about the QIP or not participating, I just want to point out that even partial credit for the ECM QIP is going to be worth the effort to your organization, both in the quality of care that you're providing to your clients and also the potential for earning even partial credit for that ECM QIP incentive. Just want to really encourage everybody to give that a shot.
Thank you, Shannon. Could you also share, as we transition to Amy McEwen's going to share even more about Partnership Health Plans program and what this could mean both financially and practically, but the enhancements to your program and your experience the first time you tried to get reimbursement for QIP and how your experience was with Partnership Health Plan.
Oh, thank you. That's a good point. So it was actually during the second quarter, we submitted on our report the group of individuals that we thought we were supposed to include information for. And it turned out that we understood that group to be a lot smaller than it really was. And because we didn't report on that full body of information, we didn't receive the full amount for the QIP. And we actually went back and advocated to partnerships saying, hey, we didn't understand this on a technicality, but we've done the work. Could we please resubmit this to you and demonstrate that we did do the work and that we're trying to meet the QIP and that we get that it's important. And partnership went back on their end and went through their processes to review that, and they agreed and they let us resubmit the data, and we ended up getting 100% of the QIP funding that was available for that second quarter.
Great. Thank you, Shannon. Thank you. I would encourage everyone to put your questions in the chat, and then Shannon's going to be with us and you can answer your questions for Shannon and Amy together as we bring on Amy McEwen. And she has a few more slides to talk about the details of this. I'm really grateful that Amy's joined us. She's the Quality Incentive Programs Manager over all of the quality incentive programs that Partnership has. And I'd like to turn it over to you, Amy. Thank you.
All right. Thank you so much. And thank you, Shannon, again, for such a great and insightful presentation. I will start off by saying that the QIP team always appreciates hearing how the provider does it or how it goes for you on your end. It's easy for us to, develop and write a specifications document, but it's the action behind all of it that really is also very insightful. And it helps us to tweak our specifications for, greater learning and greater understanding, which I'll speak a little bit about more as I go through, much to Shannon's experience, because she's not alone. We've experienced this probably each quarter as the program has moved forward and continues to grow, because we are always adding new providers, right? And this is not the easiest program to really wrap your brain around the first quarter. It really does take almost an entire measurement year. So with that said, I am filling in today actually for Deanna Watson, who is the program manager for the ECM QIP. She wasn't able to join, so I'm going to step in for her. So if you do end up reaching out to the inbox, it will be Deanna who you speak with. I do act as her backup, though, for all things ECM QIP. So next slide, please. All right. So just a general overview, this particular quality incentive program launched in 2022. It is one of 6 that we offer. The one LTC QIP that we have has sunsetted, but it is transitioning into something a little bit different, but it hasn't gone away completely. So I do still like to say that we manage 6 QIPs within the quality department. The ECM QIP, like the majority of our programs, is a calendar year. It starts on January 1 and ends the last day of December. What is unique about this program that separates it from the rest is that we operate on a quarterly payment basis. Most of our QIPs are paid out one time a year, with the exception of our palliative QIP. That is a biannual payment. But this ECM QIP is much different. Not only is the program different in the way that it's executed, but the provider demographic is also very different. We don't just have all PCPs or hospitals participating in this or palliative. We have, non-PCP sites, homeless shelters, and everything, that a really good mix that is operating within this program. And so this one factor, I would say, keeps us as a QIP team on our toes the most, and offers us the most opportunity for provider education and collaboration to really refine this QIP to meet the need, not only the needs of the providers to execute, but also to meet the needs of the members that qualify for the services. So you can see there on the right-hand side that the incentive payout is really a good snapshot of just how much this program has grown. In 2022, it's a pilot year. We paid out about $800,000, a little bit over. Q1 through Q3 was one measure only, with a big change in Q4. So what's one measure only mean? It was just a timely reporting QIP. I want to say it was relatively simple, but that's undercutting, I think, the effort that went into really getting those timely reports in. It's a lot of work. I tip my hat to anybody that participates in ECM. It's a lot of work to get these reports in on time and to really coordinate with partnership through the various methods we have for getting reports to you, for you submitting them to us. So while it was a straightforward payment for timely reporting, it was still pretty complicated and it was new. So that was the other added feature there. In Q4, we kind of made an aggressive move to take this out of that pay for reporting only and take it into a more of a quality a QIP. And we did that in Q4 by adding 3 new measures. We had 67 providers initially, and you can see there in 2023 that we jumped from about 800,000 in payout to almost 2 million, with an increase to providers from 67 to 168. Next slide, please. All right, so I like to give the timeline. This is kind of the farthest step back. I always tell folks, if you put me in the Hunger Games, I would die instantly, because I cannot be dropped in the middle of a forest and told to go get my food and run for my life. I have to ask all the questions. I have to understand who's given the orders. I would be the first to die. So I always have to look at a timeline. The timeline here says you are here, much like you would be in the mall. If you were going shopping, you're here. We are a little bit farther along, though, than this, but you can see that where we're at, we are getting ready to collect depression screen and blood screen data, or blood pressure data. That would be really weird. Templates are due with the data. Deanna receives those from our ECM team, and then she begins to validate that data and begins to really jump into a very involved tracker process, highly manual. When we started off these particular measures, that depression screen, blood pressure screen, entries into collective medical, when that implemented in Q4 of 2022, it was straightforward for us to do an audit in collective medical. It was hundreds and hundreds that we were auditing. But as we grew towards that, 1.9 million distribution in incentive payments, we had to kind of shift gears in how we audited in collective medical. So now she employs she audits the first 8. If they pass, it's a 100% pass rate. If one fails, then we add more and do a further audit. And that has really helped us to be able to manage the growth of the program, because she is the only program manager for this program. Like I said, I'm her backup. She's got it down. Oh yes, collective medical is now point click care. Forgive me, I am always forgetting that. So thank you for that reminder. But so we're always looking for ways to really make this as efficient as possible. And of course, with 100% accuracy, the goal. So next slide, please. Okay, so this is just a quick look at our measure summary. You can see there that the timely reporting has remained. However, it's transitioned from pay for timely reporting to now a gateway measure. What does that mean? That means that the timely reporting determines your pot of money, the dollar amount that you could earn for the 3 quality measures that are listed there. And I'm going to go into more depth on those as we transition through the slide. So next slide, please. All right, so our reporting gateway measure is really based on that timely reporting. You're still accountable for getting in timely reporting to the ECM team. If you turn in those reports, all 3 in on time, you earn 100% of the incentive dollars. If you are 1 week or up to 5 business days past due on any of the reports, you will earn 50% of the dollars available. If you're late, past that 5 business days, then you'll earn 0. And what that does, that goes into a pot of money, translates out to $100 per member per month. And that determines your incentive pool, which is divided between those 3 quality measures in percentages. Next slide, please. All right, so starting with reporting measure 1, this is our care plan and release of information submission into Point Click Care. Of course, this is a measure period of quarterly. We pay out quarterly. The pool of money divided here is 30% of the total incentive pool is designated to this measure 1, with greater than or equal to 80% of approved submissions into Point Click Care earns you full credit, or 70 to 79% will earn you partial credit. Next slide, please. Oh, you know what? If you could go back just one, I just want to call this out real quick. Deanna does make a note in here that any partnership or DHCS release of information forms have a 5-year expiration. So we know when we see those, we've got 5 years. So if you were to talk to me in 5 years, we probably would have a lot more to look at and audit. But right now, it's kind of nice when we see those. So that's just a little call out there about that 5-year expiration. Okay, next slide, please. All right, so measure 2 is the depression screen using the PHQ-9. And so here we collect these depression screens. We audit every single one of them. If you have an approved depression screen for greater than or equal to 90% of the total amount that are received, then you will earn full credit. Partial credit is between 80 and 89% of approved depression screens. New now, though, is we have added a new depression screen called the Geriatric Depression Scale Short Form, or GDS. And we've also added the PHQ-9 OV, standing for observational version. If you are in need of those, anything related to any of these measures, whether it's a template or any kind of supporting documentation, you can reach out to Deanna at the QIP or ECM QIP at partnershiphp.org. Each of our QIPs has their own inbox. Deanna manages this particular one. If you're in need of anything to get information to us, or you're not sure what are these new depression screening forms about, you can go ahead and email us at that inbox that's Ashley put into the chat for me. Thank you so much. And we can get that out to you. If you have a question, I think it's really important to note too, which I thought about overnight since I gave this yesterday. If you have a question, anything related to any of these particular measures, please don't hesitate to reach out to Deanna. We have medical directors that we have available to ask questions about these depression screen templates and tools. And we get quite a few questions about different scenarios, and they are very quick to answer and very quick to get answers out to you in order to support. It is understood that these payments go out much quicker than the other QIPs. So this particular QIP is looked at as a priority. Next slide. All right, kind of rinse and repeat here. It's just for blood pressure monitoring, much like the depression screen. Again, 35% of the total incentive pool is designated for this particular measure of the total amount of blood screens submitted. If you have greater than or equal to 80% that are approved, you'll earn full credit. Partial credit is looking at between 70 and 79%. And everything needs to be submitted on a screening template. And we do have specific templates for each measure. And like I said, if you are in need of those, you can reach out to the QIP inbox to get those. And we do define what we are looking for in terms of a normal screen. And we do state that if you do have an abnormal screen, that you need to repeat that screen each month until you have a normal screen. Next slide, please. All right, so this is the best slide, honestly, out of everything. So the following providers who you are looking at scored between 85 and 100% on their, scored between 85% and 100% of their submissions, and they earned 100% of their incentive pool dollars. So for the Northwest, the Humboldt and Del Norte counties, that would be Arcata House Partnership. And there you can see for Southwest, which includes the Lake, Mendo, Sonoma, and Marin counties, we have a list of providers that earned 100% of their incentive pool. And down there you can see COTS, who Shannon so graciously gave her presentation before me. So one thing that I wanted to point out that I think Shannon displayed really well is the attention to detail that she described that is really required for this particular QIP. So, you know, none of these measures are captured administratively. right? In our other QIPs, we have some providers that, you know, we have a mix. We have administrative measures, we have manual submission measures. Maybe they don't want to participate in the manual submission measures. That is really their prerogative. It is a QIP, so we're not forcing you to participate. And they just rely on that administrative data capture. They don't have to do anything. It's an automatic generation of data. And so we then are able to incentivize based on that capture. And so, but for this ECM, this is all manual submission, and it's a pretty gnarly manual submission, and it requires some heavy attention to detail. So when I hear Shannon describe how they do their process, how they keep it before staff, how they're constantly talking about it, I really have a lot of respect for that, because that is honestly what it takes. The other thing that I want to highlight is her comment on coming back to us and saying, hey, maybe your specs were not as clear as we'd like them to be. Or I read this in the specs document and I didn't understand that, or I interpreted it in a different way. Partnership is not intending to be punitive in any way. Like, it is not our intention to withhold money. It is our intention to incentivize your performance and to make sure that you get the dollars that you have earned. So if you're ever in a place where you're unsure about something, or you submitted based on an interpretation that you think you see now in a preliminary period has not earned you the dollars you thought, always come back to us. We're always able to go back and look and course correct if needed, or even provide further clarification in our specs. You'll see that our specs document since 2022 has been revised so much, because this is really our most, I would say loosely, our grassroots QIP. This has been built from the bottom up, and we all know CalAIM is a beast. We're all learning it as we go. No one came into CalAIM being experts. You know, I think maybe we probably feel like experts now, but we're all learning as we go, and we're doing this together. So I just would like to encourage you to really keep that in your heart in terms of how you execute this program, and really see us as partners with you to get you the dollars that you earn. Next slide, please. So tools and resources, you can click into these when you get your slides. Folks ask for best practices for blood pressure monitoring. They also ask for, you know, maybe if they need monitoring kits, we're able to help you with those. PHQ questionnaires, and then of course contact information. And we have a webpage. Each of our QIPs has their own webpage, and so there is the ECM QIP webpage. Next slide.
And Amy, I'm going to actually
There you
pause
go.
this at questions. Thank you so
Yeah.
much. I'm going to
Yeah, you
ask
bet.
people to put in their chat, continue to put in the chat questions you have specific for Amy, as we're running low on time, but we know that you may have specific questions. Right now, we want to pull up a poll, and we're actually going to send you a link in the chat as well to the resources that Amy shared. But right now, Jessica's going to pull up a quick poll, because one thing partnerships offer to do is help us get some things like blood pressure monitoring kits to you, or more training on depression screening. So we want to hear what you are working on right now in terms of QIP work, and then we want to hear a little bit about your interest in meeting in person to get some on the ground training for you and your employees. We were looking at doing it in August, but partnership is working with us to do that even sooner if there's interest. So there's 2 questions here. We're going to give you just a minute to respond to. Thanks, and be sure to scroll down like you have to on mine and to really let us know if you'd like more training. I'd like to encourage you also to fill out the evaluation today, because there's some open space for you to also share other ideas about how you want to take this information, not just as data to be collecting, which is so important in CalAIM to be collecting data, but really how you're using it, or how you'd like to learn to use it more in your complex care management, in your program improvement ideas around multidisciplinary case management, as well as again, getting more nuts and bolts on how to administer the screening and blood pressure tools with your care management teams. And then we also just want to, in the last few minutes, as we collect your poll information, we also want to highlight a couple of upcoming opportunities to meet with us in office hours. We have office hours on Monday, and we'd love to connect with you about the new CalAIM budget estimator that we sent out. If that would be helpful, we can help you review your IPPs. We really want to start to develop office hours in a way that's most meaningful for you, even if it's to take a deeper dive on some of the questions that may have evoked through Shannon and Amy's sharing today. And I just want to make sure with Jessica and Catherine, if there's any questions in the chat that we need to address with Amy before we transition to the end of the meeting.
I don't think so. I'm not seeing any.
Okay, great. Well, really appreciate Amy and Shannon sharing today, and really working with us on the next steps to get more providers engaged in the QIP opportunity, both from the data collection, the revenue enhancement, and the program improvement perspectives. And our upcoming office hours, we're looking for your input. I'm sure will be a topic of our next few weeks of really how to make these the most meaningful and helpful to you. Whether it's changing the time or changing the topics, it's actually something that we're posting now monthly as part of our contractual requirements with the state and PCG. So thanks, Nancy, for being with us. And with that, I'm going to actually transition to our post-event evaluation, where again, we have some really key questions that we'd really love to hear from you for our post-event evaluation. And I'm going to turn it to Catherine to close this out.
Thank you, Tammy. And thank you, Amy and Shannon, for sharing. It was great. And Sean, we're really excited that you were here with us. And again, please do take a few minutes to fill out the post-event evaluation. It is extremely helpful for us in terms of planning and making sure we're doing a good job to support you in the hard work that you're doing. And I think with that, we can just take this last minute to give you a minute to fill that out. And I believe it also pops up when you leave the meeting. So there's many options to give us feedback. So yeah, thank you so much for joining us. And hopefully we can see some of you in office hours. And for the rest of you, we'll see you next month. And please do reach out to us with any questions or needs or ideas that you think would help these times together be as supportive as we can be for you. So thanks, everyone. I hope everyone has a great rest of their day and enjoys some extra daylight hours this evening.